the entire series is going to be taken by Dr. Tapesh Bansal himself. It is going to be on basics of mechanical ventilation, and uh, it would be the best start to a day-long session on mechanical ventilation, starting with the basics of mechanical ventilation. So, without wasting much time, I would invite him to start his lecture. He's basically founder of Young India Intensivist, and what should I say, is the convener of today's program. So, can you please start your talk?
Thank you, Dr. Niklesh. I will start the scheduling and the lecture. This is the lung and the respiratory wall, which is moving in opposite directions because the lungs and the respiratory wall are not attached in parallel, they are attached in series. If we think of the circuits that we have in electricity, that is the way the mechanics are. And here is the assist volume control screen, which is common to all of you. And this is a pressure scaler. So this is a very basic thing which I'm going to tell you, especially for the younger ones. And here, this is the pressure rising when the flow starts. And this is called the conductive pressure. And then the pressure builds up as flow builds up, and you hit the P peak. And normally we like to keep the P peak less than 45. And after the P peak, we have an inspiratory hold, which we normally set at 20 to 30% of the inspiratory time, or we can have a bedside inspiratory hold, which is around 1 second. So once we apply an inspiratory hold, we can tease out the difference between the P peak and the P plateau. Otherwise, if we don't give an inspiratory hold, we cannot get a P plateau because everything is happening so fast. So we need to give an inspiratory hold. Now, one thing which you may not know is that P plat has two components, P1 and P2, right? P1 occurs when there is stress relaxation of the entire circuit, and P2 occurs because of pendulum. Normally, the ventilator gives the average of both these two, and it is important to know for theoretical reasons and sometimes other reasons about this. Okay, then we have this P plat, and P plat we like to keep less than 30 in ARDS, and the difference between P plat here and PEEP here is known as driving pressure. And driving pressure we like to keep less than 15 as per the Amato study, and it is not that we can keep it as low as possible. Some people or somewhere in literature written go as low as possible. If you go less than 10, then you can get atelectatic trauma. So it is between 15 and 10 that we like to keep the driving pressure. Now, coming to plateau pressure and transpulmonary pressure. So plateau pressure is equal to transpulmonary pressure plus pleural pressure. So these are just exemplary numbers. It can be anything. So when you have a plateau pressure, you get a transpulmonary pressure, which is a distending pressure of the lung, and at the same time, the chest wall is also getting distended, and you get a pleural pressure in the chest wall cavity. And if you want the transpulmonary pressure, you just take it this side, and you would take the plateau pressure this side. So the transpulmonary pressure becomes plateau pressure minus pleural pressure. So that way you get the transpulmonary pressure, and this is the distending pressure of the lung, and this is the injurious one. Now, if what is the transmission of plateau pressure to pleural cavity if chest wall compliance is normal? Please note, if chest wall compliance is normal. So the normal lungs, 50% gets transmitted to the chest wall cavity, and in ARDS only 20%. Okay, because most of it is used in distending the lungs, and in emphysema 80% goes to the pleural cavity. So these are just the rough numbers, but the chest wall compliance has to be normal. If the chest wall is stiff or more compliant, then these numbers change. Now coming to stiff lungs and compliant lungs, just carrying that forward. So E stands for elastance. Elastance is opposite of is 1 by compliance. All right. And elastance is used because when you're doing all these calculations, then it becomes easier. Elastance is the stiffness of the lungs and how difficult it is to stretch the lungs, while compliance is how easy it is to stretch the lungs. Okay, so here you have stiff lungs, and P, this is the airway pressure, P paw, and you can see the PL below that and the P pleura. So in stiff lungs, the transmission to the pleura is very less in green, the green arrow. So the transpulmonary pressure, which is blue, is much higher. Okay, and in compliant lungs is the other way around, which I just told you. The emphysema lungs is a compliant lung. And the same airway pressure, the blue arrow is much less. That is the transpulmonary pressure, where the pleural pressure is much higher. And if you see the arrow below on the left side, venous return is much higher in stiff lungs because the pleural pressure is low. And pleural pressure is low means the compression of the right atrium is less. And it's vice versa in compliant lungs. And these are the formulas which we are talking about. Elastance is equal to 1 by compliance. Elastance of the respiratory system is equal to elastance of the chest wall plus elastance of the lungs. And 1 by compliance of the respiratory system is equal to 1 by compliance of the lungs plus 1 by compliance of the chest wall. These formulae should be known because if you want to understand the respiratory mechanics, you got to know these formulae. And the P, transpulmonary, this is a very important pressure. This is the pressure which causes injury to the lungs. It's not the plateau pressure which causes injury. You want to keep plateau pressure less than 30 because it's easy to calculate. The transpulmonary pressure is not easy to calculate, but that is there in understanding of the respiratory mechanics. So transpulmonary pressure is equal to the plateau pressure or the alveolar pressure, the pressure in the airway into elastance of the lungs over elastance of the respiratory system, or you can invert it because elastance is equal to 1 by compliance. So you can get compliance over respiratory system and compliance of the lungs. Now you look at this diagram here, there is P alveolar, that is the intra-alveolar pressure or the P plateau pressure at end inspiratory. And it's 0 at end inspiration in normal breathing. And then there's P pleura, which is anything like 5 to -10 at end inspiration, because the tendency of the lungs to collapse to the pleura is negative. So this is normal breathing. Now, if there is ARDS, okay, or acute respiratory failure, then there's a wide pleural sphincter. The pleural pressure is much more negative. And I told you the formula for transpulmonary pressure. So you get a transpulmonary pressure which is high, which is causing injury. So when there's a lot of pleural swing, as in respiratory distress, you get high transpulmonary pressure. So what do? You apply NIV. One of the modes is apply NIV. So by applying NIV, you want to decrease the pleural swings, right? And if you decrease the pleural swings, you will decrease the transpulmonary pressure as per the formula. So when you apply NIV, if you get a decrease in pleural swings, the job is getting done. But what happens sometimes is that you do not get that particular situation. When you apply the pressure support, your P alveolar will become high, your plateau pressure will become high because you're adding positive pressure, and the transpulmonary pressure will become high. So what happens is the patient is not improving on NIV. Sometimes we increase the pressure support. So there we are increasing the alveolar pressure, the plateau pressure, and thereby the transpulmonary pressure. So this is erroneous, and we have to be mindful of that. And this is not uncommon. Pressure is not improving. There's a tendency to increase the pressure support, and thereby we are causing more injury because we increase the transpulmonary pressure, because the transpulmonary pressure is equal to the P alveolar pressure or the plateau pressure minus the pleural pressure. Now, what factors can alter plateau pressure? So one is your tidal volume, second is your PEEP, extrinsic PEEP, intrinsic PEEP, and the third is the compliance. These are the most important things. And fourth is the compliance of the chest wall. Okay, these factors determine the plateau pressure. So sometimes if you're wondering what is going on with the plateau pressure, think of these factors. Now, what is the difference between ITP, intrathoracic pressure, and pleural pressure? So the intrathoracic pressure is practically the same as pleural pressure, but there are certain nuances to this. And how much of intrathoracic pressure or pleural pressure affects the CVP? So this is a very controversial thing, and you may get different answers from people, but the correct answer is most of the pleural pressure affects the right atrium of the CVP. If the pleural pressure is something like 10, then your CVP will go up by 8, 9, and the venous return will be decreased because the right atrium is abutted by both the lungs by the thoracic pressure with the pleural pressure. Now, factors affecting intrathoracic pressure. So best estimated by pleural pressure, which is a surrogate for intrathoracic pressure, but it is not the same because factors like diaphragmatic movement, intra-abdominal pressure, alveolar pressure, pericardial pressure, hyperinflation, they do affect the intrathoracic pressure. So I think this distinction is very important, especially for getting your concepts right. Now, what is strain? We'll come to strain and stress. So these are the fundamentals, basics of mechanical ventilation. Strain is the change in volume of the lungs over and above the FRC of the lungs in ARDS. So FRC is what you get, functional residual capacity, when the lung has expired and is resting. Okay, and if you see the diagram, in blue there is FRC, and above that in pink is tidal volume plus the peak volume. So this tidal volume plus peak volume is the volume that is changing, and FRC is already there. So this ratio is called the strain. And there's dynamic strain and static strain. When the lung is resting at end inspiration and end expiration, it is static strain. And when the lung is moving, it's dynamic strain. And for obvious reasons, dynamic strain is more injurious because the lungs spends more time in dynamicity, in moving up and down, inflating and deflating, and there's more shear and stress during movement of the lungs. Then what is stress? So stress in the lungs is a distending pressure. Stress in the lungs is a descending pressure and is a result of transpulmonary pressure. It is not precisely the transpulmonary pressure, but the way you look at it, the way you measure it is the transpulmonary pressure. And its definition is the force per unit area acting in the lungs. And stress in the lungs is not uniform throughout the lung. It is different in different areas because there are stress markers in different parts of the lungs. The pleural pressure is different and so on and so forth. Now coming to stress index. So what is stress index? So stress index, I told you stress is a transpulmonary pressure, but stress index is not transpulmonary pressure. This was a concept developed 20 years ago when we were still in infancy as far as ventilation was concerned. And this tries to give you an idea of how much PEEP should be set in ARDS. So the stress index is 1, you're doing wonderfully well with your ventilator settings. If your stress index is more than 1, you're over distending. And if your stress index is less than 1, that means there's some scope for adjusting your ventilator settings, giving some PEEP or giving some volume. Okay. And who gives the stress index? The ventilator gives you the stress index, and there has to be the software in the stress for in the ventilator. Okay. And the thing is that the patient should be paralyzed, volume control, no leaks, etc. The other thing is you can actually eyeball also sometimes because this may not be available in all the ventilators. You can sometimes eyeball and look at this particular graph. This is a pressure scaler and see how you're doing as far as your ventilator settings are concerned in ARDS. Or you can just freeze it and kind of have a look at it. This is also possible, but that is the concept of stress index. And below is the formula. There's a mathematical scientific formula also for stress index if for people who actually want to go into more details. Then moving on to specific elastance. So stress over strain, which I just talked about, is known as specific elastance. And the human beings lungs have a particular specific elastance, and the elephant's lungs has a particular specific elastance. The rat's lungs has a specific elastance which is different. So animals have a specific elastance in the lungs which is different in each animal and different from human beings. And stress over strain is specific elastance. And stress and strain are related by this particular specific elastance by multiplication. If you multiply strain into the specific elastance, which is K, you get stress. And you do not want strain to go more than 2.5. And if you know stress, which is the transpulmonary pressure we're talking about, the end transpulmonary pressure, we do not want to go more than 26. So there's a beautiful relationship coming in here, as you can see, very scientific. Strain should not be more than 2.5, and the end inspiratory transpulmonary pressure, which is the stress, should not be more than 26. Now, what is specific elastance? To understand it, it is the intrinsic elastic recoil, tensile stiffness of the lung tissue produced mainly by collagen and elastin in the extracellular matrix of the lungs. And the rest of the lungs rests on this particular extracellular matrix, this particular framework of collagen and elastin. And if you have increased strain or stress, you get volume trauma and barotrauma. This is a slide showing you FV loop, which shows airway obstruction. On the left side is the normal kind of a FV loop. If you see here, below is inspiration and here is expiration. And this is very straight, right? Because there is no obstruction, so it goes smoothly. And the shortest distance between two particular points is a straight line. But when there is obstruction, you get this is called scooping. And this means obstruction. So by just looking at the FV loop, you can diagnose obstruction, which may be due to COPD exacerbation, asthma exacerbation, blocking in the tube, secretions, etc. So sometimes it is very helpful. You sometimes don't get a history of COPD exacerbation. There's nothing in the X-rays. You don't know what it is. So, but if you look at it, you can make out. So, guys, that was the first part, just the basics of mechanical ventilation. I hope you found it useful. And now I shall talk about something which is very exciting, which may fundamentally change the way we set the ventilator in ARDS. Work is in progress, but I will just apprise you of this concept. So are we estimating mechanical ventilation wrong in ARDS? Are we estimating mechanics wrong in ARDS. So this phenomena, which is being studied now, which is emerging, is called airway closure. Airway closure, and this was identified by Chen et al. From University of Toronto, from Dr. Brocha's lab himself, the great man's lab himself, and reported in the Blue Journal in the year 2018. Subsequently, papers have started coming in, and work is in progress. So what is airway closure? Dynamic or sustained occlusion of conducting airways during expiration, where distal lung units become non-communicating with the ventilator, right? So you are pushing in air, but it's not going in. And prolonging expiration does not prevent it, unlike asthma or COPD, where there can be airway closure. So that is airway closure, and this is in ARDS. We're talking about ARDS here, not asthma or other conditions. So this is the recently described phenomena, and just gave you more information on this. This has been seen in 30% of ARDS patients. Approximately 30% of the patients have this airway closure. And this is the high resolution synchrotron CT. And if you see from right to left, here you see, if you follow the marker, there is no airway, right? PEEP is 0. And as you go on increasing the PEEP here, you start seeing the airways opening. Okay, these are the airways opening, and this is the reconstructed airways. This is the alveoli, and these are the airways opening up. And this is another reconstruction, PEEP 0, PEEP 12. The airways are collapsed, and the airways start opening up. So this phenomena is very important to understand, because the airways are closed. How is the air going to go in? If you are setting a PEEP, the PEEP is below what is required to open up the airways. The air is not going to go in. That is the fundamental concept.
Sir, 8 more minutes.
Now, why does this occur? Why does this occur? It occurs because of problems with surfactant dysfunction, which we know occurs in ARDS. There is FRC loss. We know there's baby lung, and there's decreased resting lung volume and loss of radial traction. There's gravity, high pleural pressures in dependent regions, and obesity. So all these factors lead to this particular airway closure, and it is still under study. It's not understood properly. So there is a method to detect this. Chen et al., who first described it in 2018. In fact, it was known before that, but in ARDS, it was described by them properly when they were doing some experiments at slow inflation of the lung at flow was 5 liters per minute. Sorry. And at slow inflation, they were able to identify this. Sorry, please. 1 minute. And the second method, which has been described by Hodaberg et al. Around 2 years ago in critical care, is conductive pressure method. So I'll just describe to you what this is. So this here, what is happening is, if you look at left, the pressure scalar on the x-axis, you're reaching a small positive pressure of 5, and the volume starts increasing in blue, right? That is what normally happens. You start giving some flows, the pressure starts rising, and the volume starts rising. But when there is airway closure here on the right, you see you are giving in some volume, very little volume is going in. The pressure has gone up. Pressure has gone up to 15, but the volume is not rising. There's no volume here. And when the pressure here exceeds the closing pressure of the airways, the airways open up, then only the volume goes up. So this is the phenomenon which is occurring, which is being described, which is being studied. And this is a magnified view at slow inflation. And see here, there you are pushing the pressure up. The pressure has gone up to 15. Volume has not gone up. At 15, it goes up and the volume goes up. And these are the cardiac oscillations at slow inflation. So 15 is just a number, because it has been seen that airway closure may require P from anything between 5 to 20. All right. And this has to be identified, because then only you can set the P properly. So using standard flow 60 liters per minute is very important, because 5 liters per minute is a very low flow. You can cause hypoxemia in ARDS patients, and many ventilators will not allow such low flows. So this particular method described by Hodaberg et al. In critical care 2 years back is called the conductive pressure method. So what is this conductive pressure method? If you remember in the first slide, I told you when you are using volume control, this particular rise is called conductive pressure initially. This is a pressure scalar here. Okay. This is the rising and this goes up. And the difference between the P peak and P plateau is called the resistive pressure. Normally, these are equal. Normally, these are equal in a pressure scalar or in the assist volume control. All right. And here, if this particular conductive pressure is more than
Okay,
resistive
we've just
pressure,
got 4 minutes for discussion. We've just
okay,
got 4 minutes
that
left.
means that there is a problem here. That means there is a problem here. That there is airway occlusion. And the difference between this and this is the difference that you need to account for in terms of P. So this is something which can be done at the bedside. And as you may appreciate, if the airways are closed, all your lung mechanics will go wrong. The parts which are open will get more volume, more air, and the parts which are closing with this airway occlusion, you will not get the volume. And all your respiratory mechanics will be wrong. Your respiratory mechanics will be wrong. Driving pressure is not equal to P plat minus PEEP, but driving pressure is equal to P plat minus airway opening pressure. That is very important, and you have to identify the airway occlusion which is occurring, set PEEP above it so that the airways open up and lungs can go to the alveoli. The alveoli are not a problem here. Alveoli are still the same, but the airways are closing. The volume will not go into the alveoli, which are probably open below, beyond it. Okay, so if PEEP is less than airway occlusion over pressure, your mechanics are false. And you are also causing villi because the airways are opening and closing, airways are opening and closing to some extent. And this, if PEEP is set below airway occlusion pressure, the baby lung is subject to massive unmeasured stress. Conventional math assumes the whole lung is participating. It isn't. The value of driving pressure and compliance is wrong, my dear friends. And that is the fundamental reason that we may be setting the ventilator wrong. And we will have to probably identify this particular phenomena, that is airway closure, and set the ventilator accordingly. So what is happening? Studies are occurring, and this is one of the largest studies which is occurring right now. The AOP went multicentric study to see if we need to identify this, whether this makes a difference, and whether we have to, in future, identify this and then set PEEP and other things accordingly. So that was about it, and I think this should be possible, and we have to look at the future studies, what the studies say. And I would like to thank my God and Guruji, His Divine Holiness Babaji Maharaj, for his blessings upon my education. So with that, that is the end of the talk, and I'll be happy to take any questions.
I have put one in the chat box, sir.
Yeah, just give me 1 minute.
Because I can take one or two only, I believe.
Yeah, how do you see the time? Okay. So just read out the questions, please, and you moderate the questions.
Okay, does this mean that the focus has shifted from tidal volume to driving pressure?
No, so in no, that is not the issue. Driving pressure is tidal volume is part of driving pressure, right? You said the tidal volume and PEEP as per the driving pressure. Driving pressure still remains the same, but this is a fundamental concept of airway closure that we have to see whether if we have to identify the patients and it makes a difference. Okay, so just difference between P1 and P2, Dr. Abdul Rashid, is that P1 comes before and P2 comes later. And when you are looking at plateau pressure, P1 is due to stress relaxation of the entire circuit and the lungs. P2 is due to pendulum.
We'll have to close the session for now, and we have
You can
to.
take 2-3 questions quickly.
Okay. Anybody else? So, let me ask, what should be the amount of P? If difference between P second, conducting pressure and pressure resistance is 1 centimeter of water.
So if the difference is one, then what you have to do is you have to look at the PEEP that you have set, and you have to look at the difference between conductive pressure and resistive pressure, right? So the difference between these two plus the PEEP will be the PEEP that you will have to set to open up the airways. So let me see any questions are there. What other questions are there?
Is it time to switch from pressure versus volume to mechanical power?
Sorry?
Is it time for switching from pressure versus volume debate to mechanical power?
Mechanical power is independent of volume control or pressure control. You can do either. It has never been shown which is superior in terms of results. The results are the same whether you use pressure control to volume control, and mechanical power or whatever you are using, it does not make any difference. And mechanical power is an evolving concept. This is not a very clear concept because there are problems with mechanical power. For example, mechanical power, you are when you are mechanical power also includes resistive flow, where that is the air that is flowing through the conductive airways, and when you're flowing through the conductive airways, that is not really injuring the lungs. So whether that should be included or not included in mechanical power is one issue. The second issue is the PEEP, whether PEEP is injurious or PEEP is helpful. So mechanical power is an evolving concept, and as a standalone concept, it cannot be taken. So any more relevant questions, or should we close it?
No, there are no more questions. So I think we can move ahead.
All right. Thank you, Don English.
Thank you, sir. Thank you.